Hello and welcome. I'm Lulu Garcia-Navarro with New York Times Opinion, and I'm the host of the First Person podcast. We are here today to talk about this extraordinary moment in reproductive health in America. And it is a very confusing landscape. When the Supreme Court eliminated the constitutional right to an abortion in June, what ensued was a patchwork of state bans and restrictions that are still being contested across the country. For example, in Alabama, a person who performs an abortion could face 10 years in prison. In places like Ohio, Wisconsin, and Louisiana, the laws say the procedure is a felony. But some of these laws have been put on hold, pending lawsuits by advocacy groups or declarations by largely Democratic officials that they won't enforce them. So where does this uncertainty leave women in half the states where a ban is in place or expected? And how does this legal and legislative chaos affect the care that doctors are providing? We're going to explore that right now with doctors from states with bans in place. And after, we're going to answer your questions with help from legal and medical experts. First, I'm joined by three doctors, all obstetrician gynecologists from places with laws in place or pending that prohibit nearly all abortions. Dr. Veronica Gillespie-Bell is in New Orleans. Dr. Kristen Lyerly is in Green Bay, Wisconsin, and Dr. David Hackney is in Cleveland, Ohio. Welcome to you all.
Thank you so much.
David, I am going to start with you because you deal with high-risk pregnancies. You recently wrote in the opinion section of the New York Times that, quote, Ohio's new law is unimaginably cruel. Can you tell me why you wrote that and what that law means in practice?
I wrote it because I found myself a couple of days after the law first went into effect starting to worry the most about the cases of fetal genetic disorders, fetal birth defects, including lethal fetal birth defects. Certainly, I was on call when the law first went into effect. I was standing in my kitchen on a Friday night, and my colleagues were texting me saying that it had gone into effect, and I said, how much time do we have? When does this actually become law so that we know when to get ready for it? And everyone said, it's a law right now. And I was on call, and I was on call for high-risk OB, and suddenly I thought to myself, when I walk into the hospital Saturday morning, Sunday morning, if I have someone who is, bleeding heavily or someone who's in heart failure, am I really going to know what to do? And you always want to know the law before you have someone who's sick. You never want to have to call a lawyer in the middle of having a patient who is sick. So the first several days after the law changed, we were really focused on the threat to death, the threat to health. And fundamentally, what we always decided is that, no matter what, we're not going to let a mother die. But then after we started to get that a little bit more figured out, the law makes absolutely no exceptions for fetal genetic anomalies, fetal birth defects, lethal anomalies, and that's what we see. So suddenly I realize I'm going to see a patient, at some point with a fatal birth defect, and I'm going to have to tell her that she cannot receive abortion care in Ohio. And when I wrote that essay, that was literally what I was doing, So.
Yeah, when you say a fatal birth defect, what you mean by that is that the child will not be viable outside of the womb because it has such a severe genetic disorder. Is that? Am I understanding you correctly?
Yes, there's many different things that we can diagnose that we know are going to be fatal. The classic one is an anencephalic fetus, where the fetus literally has no brain. It is rare, but it is something that we see. I have had to tell women many times that they have a anencephalic fetus. And a fetus with no brain has no chance to live. Telling a woman it's an anencephalic fetus is just about one of the hardest things.
We seem to have lost David there for a moment. I'm going to turn to you in the meantime, Veronica, while we try to get him back. As we heard him discuss there, what we're talking about are these incredibly difficult conversations that you have to have about some of the most personal things that you can possibly discuss. You are a general OBGYN in Louisiana. Right now, a judge there has blocked the almost total ban on abortions from being enacted. But it's been this legal back and forth, right? I mean, can you take me into your practice? What does the sort of fluctuating state of the law mean for you and your patients? As we heard there, David saying it kind of hit him like a shockwave. But if the law is changing back and forth, what kind of conversations are you having?
You know, I think what I'm seeing the most from all providers and from patients is fear. And like you said, it's so complex and it's changing so much that I think it makes it very difficult to understand how to move and how to counsel our patients. I'm seeing mostly from my patients, they're concerned about their reproductive rights in general. So we've definitely seen an uptick for patients coming in wanting long-acting reversible contraceptives or even permanent sterilization because they're just unclear of exactly what the ramification is.
And I just want to understand the law where you are, which is at the moment, obviously, it's being contested. But as we heard David there say, you might not be able to give care, even in the case where the child might not be able to survive outside of the womb. Is that your understanding also of what might be happening in Louisiana?
In Louisiana, I think that it's changing so much. That's not my understanding, but again, it's changing so much that it makes it difficult to know exactly where things are going to land. I think, you know, being here as a representative of ACOG, I think that's what we're seeing across all of the states. And it makes it very difficult for organizations that normally guide us and normally lead us as physicians and tell us how to manage different conditions and how to take care of our patients. It makes it difficult even from a national standpoint for these organizations that we trust as physicians as our guide to be able to give us any guidance. There is just so much change in each state. And as you said, it's just in flux in a lot of states.
And we should say that ACOG is the American College of Obstetrics and Gynecology. Kristen, I'm going to bring you into the conversation. In Wisconsin, abortion is now banned, except in the case of the life of the mother being threatened. What has changed for you personally, and what are you seeing as the fallout there?
Well, Lulu, I couldn't agree more with my colleagues about everything that they've said, especially what Dr. Gillespie-Bell said about fear. What we are seeing in Wisconsin is that patients are very confused, they're very afraid, and they're asking us questions like, if you have to make a decision whether to save my life or the baby's life, how are you going to pick? This is such an unfair situation. Here in Wisconsin, we have reverted back to an 1849 law. This law is 1 year older than the state of Wisconsin, and it was written 70 years before women earned the right to vote in this country. This law does not apply, and we truly believe that it's not enforceable. But there's so much at risk for us as practitioners, because if we were to perform an abortion and we were to be charged, it would be a felony, and that would ruin our careers and, for many of us, our lives. So at this point, we are doing the best that we can. We took an oath to take care of our patients, and we are trying to ensure that they have the best information, the most resources that we can provide for them. And luckily, we have states neighboring us in Minnesota and Illinois that have ramped up their services, so many people can still access services, although it's obviously much less convenient. But still, there are many people in rural areas, from the BIPOC community, LGBTQ community. There are so many people who are already facing so many barriers that this is just so fundamentally unfair.
Let me ask you just briefly, what do you say when they ask you that question? What would you do? What can you say?
Hey, we know these patients. We are taking care of them in their pregnancy. So we have often a relationship already with them, and these are established pregnancies. My colleagues and I who have discussed this, the first time that we hear this question, it's so jarring. It's so unbelievable. One of my colleagues said that she was brought to tears. She actually had to leave the exam room because she couldn't believe that she was being asked this question and she was faced with this decision. What we're trying to do is provide as much reassurance as we can. That's all we can do right now.
I'd like to get the three of you in conversation now that we have David back, because what I'm hearing from all of you is that there is a lot of confusion about the laws, what is allowed, what is not allowed, what you can say, what you can't say. Can you take me into some of the discussions that you doctors are having amongst yourselves? David, I want you to start, but please, Veronica and Kristen, jump in. I imagine it's good to talk to other doctors with from states with bans.
I mean, it's been in the news, but one of the big questions that we have is child rape. We do not know right now if we have a rape pregnant 11-year-old or a 12-year-old who walked into someone's office in the state of Ohio right now, what type of care we could give to that person. That's not a political issue. That's a issue of we as doctors do not know what to do right now in terms of our patient care. We know that the Attorney General believes that we can provide an abortion care to a 10-year-old, though we know that from something he said in the news media and not something which was officially said. And the decision-making is based upon what physical damage would be done to the child's body, not based upon the emotional trauma. So us as doctors, we have to try to figure out the grim question of how young, how small does the patient have to be for there to be a sufficient risk of physical damage to her body for us to be able to be allowed to provide her with abortion care. So I, as the ACOG chair, I have to go back and look over the studies and the research on this horrible question, and it's all unfair. I did not write this law, I'm not supporting this law, and we are not getting guidance from our Attorney General.
Veronica and Kristen, please jump in. I mean, what conversations are you having amongst yourselves in your respective states? I mean, what are you hearing from your fellow doctors? What are their concerns?
I think the thing that we're seeing the most, the thing that we're talking about the most, that I think others outside of myself and my colleagues are not talking about, are the disruptions in care that we're seeing, and to all women. So there are medications that are used for abortion, but they're used for other things in healthcare. We sometimes use them, for example, misoprostol is a medication that we use to soften the cervix if we want to place an IUD for contraception. And because pharmacists are scared about what the ramifications are going to be and what the intent is going to be, they're having trouble, the patients are having trouble even getting the medications filled. I'm hearing that patients that are on methotrexate for rheumatoid arthritis are having trouble getting those medications filled. So what we're seeing, and the reason that I am concerned about maternal health in general because of this, are the disruptions in care. We know that we are a country that has the worst maternal mortality rate of any high-income country. And we know that when we have disruptions in care and our systems of care break down, that our maternal morbidity, maternal mortality goes up. And as someone that has fought for many years for health equity and for Black maternal health care and improving our Black maternal outcomes, I am scared that our Black mothers are going to suffer the most. We know that in this country, 3 to 4 Black women die at a rate of every 1 white woman. And if we have disruptions of care, if we have, as was mentioned by my colleagues, if we have delays in care because we have to consult with our legal team before we can make a decision on how to manage a condition, those are things that are going to affect maternal morbidity and mortality. And so that's what my colleagues and I are talking about, and what can we do to prevent those downstream outcomes?
So I'm going to turn it over to you, Kristen, and for you, the same question, which is what are you hearing and what are you discussing where you are?
Hey, I I agree, of course, with my colleagues. And one of the things that I've been hearing in a very pronounced way amongst my colleagues is that we're concerned about the criminalization aspect. With what happened with the physician who took care of the 10-year-old rape victim from Ohio and how she did everything right. She provided quality, evidence-based, compassionate care to this child in an incredibly difficult situation. Yet the Attorney General went after her. And our malpractice insurance does not cover criminal activity. So here she is just trying to do her job, doing it well, and she's under fire. Those of us who practice in states with criminal bans are asking ourselves, can we do this? How long can we stay in a state where we're not allowed to practice in a way that we have been trained to practice and that we know is right for our patients? This is profoundly bad in places like Wisconsin, where we already have a physician shortage, especially in rural areas. And the pipeline will dry up if we're not able to train medical students and residents. And those training opportunities are fading with our ability to take care of our patients.
David, is that a concern where you are as well? I mean, is there just an actual concern that the very practice of what you do could be criminalized even when you're providing medical science-based care?
Oh, yes. Not just me in high risk, but certainly my colleagues, also everyone in OB/GYN is used to legal risk. I take care of high risk obstetric patients. So thus, medical legal risk, the risk of lawsuits is, part of what I do. But criminal risk, as my colleague said, is a total zebra of a different stripe. And again, not to repeat the same thing, but it's not covered by our medical malpractice insurance. If I'm in the hospital and I, punch someone, my medical malpractice doesn't, cover that. So if we face criminal charges, and let's say they are bogus charges, and let's say we do successfully defend ourselves, we will have to potentially pay for that out of our own pocket.
Veronica, the last question is to you. How are your hospitals and clinics advising you? What guidance are they giving you in this moment where everything is so unclear?
Yeah, and I mentioned, from an ACOG standpoint, ACOG has been very vocal in saying that abortion care is essential care, and so they've made that statement very clear. And I think hospitals in general are, as physicians, are doing the best they can. They're trying to weed through the legal changes, and again, it's in flux, and trying to advise physicians of the current legal state. I think, in addition to not just that, I think I've seen hospitals be very supportive and understand what a challenge this is to us as physicians. I personally feel very heavy. We have been challenged because of the pandemic, and not out of it. We're back into another surge. So we're challenged because of the pandemic. We're challenged because of healthcare shortages, and now a challenge of, as my colleague said, having a fear of going to jail for practicing good, safe medicine. And so I am seeing hospitals understand the stress that we are feeling and the stress that we are under as providers, and providing that emotional support and that ability to again, just to make us feel secure in that they support us and support our wellness and our well-being.
I want to thank you for joining us and sharing your stories on this incredibly important topic. That's Doctors Veronica Gillespie-Bell in New Orleans, Kristen Lyerly in Green Bay, and David Hackney in Cleveland, Ohio. Thank you all very much.
Thank you.
Now, before the Supreme Court decision came out, the Times had asked readers to tell us about a time when they considered having an abortion. We asked for these stories because the reality of abortion and how it's experienced is often far more nuanced and complicated than the political debate around it. Here's some of what we heard.
I had an abortion earlier this year, and you're only the third person I've told. I am religious, and so at first I attributed maybe this is a plan from God, that this was some kind of divine intervention to give us a third child that we had not planned for. But then I also realized if I attributed that act to my God, then I also had to attribute the fact that my daughter's cells migrated into leukemia. So I didn't attribute either to God and instead attributed it to some huge amount of fertility that I somehow still have at 37 years of age. So I did get an abortion, and I remember just crying tears throughout the whole process, tears for loss of something that I had never even wanted, and partially tears of shame as well.
It was winter, and I was 16 and not very worldly. I was interested in pot and rock and roll and not holding on to my virginity. No one stopped to consider my feelings. I just remember this kind of freight train effort to get an abortion for me. And I had lots of fantasies about raising a baby, and certainly no one was thinking about my ideas or the losses that accompanied having an abortion. My parents were connected, and they quickly found 2 psychiatrists willing to sign paperwork. And before I know it, I was shuttled off to a maternity ward of a large hospital in Washington, D.C., where the nurses shunned and shamed me quite openly before giving me a general anesthetic.
I got an abortion when I was 28 years old and an intern at Bellevue Hospital. The most remarkable part of the experience was that I was pretty solidly pro-life until the minute I found out that I was pregnant. I went to Notre Dame, and my friends and I used to sort of talk hypothetically about, oh, of course we would give it up for adoption, which was ironic because most of us were not having sex by that time. I think the most remarkable part of everything for me now is I deal with so many women the minute they find out that they're pregnant, and they are shocked and scared, and being able to take this experience and give them a non-judgmental, supportive voice to say, look, regardless of what you decide, you will make the right decision. And just the relief that comes to their face, it's really, really remarkable.
With all the news of legislation and lawsuits, as we've heard there, it is so hard to keep track of what's happening. We received hundreds of questions from readers leading up to this event, and we have 2 experts to help us navigate the legal landscape and the changing clinical practices that we just heard discussed there earlier. We are joined now by Kim Mutcherson, law professor at Rutgers Law School, and Laura McIsaac, an obstetrician gynecologist at Mount Sinai in New York. Welcome to you both.
Thank you, Lulu.
We saw many reader questions, as you can imagine. For example, here's one from Laura in Easton, Pennsylvania, and from Jenny in Los Angeles, California, where there was a lot of confusion and worry about whether these abortion bans could also penalize pregnant women. Kim, can you tell us more? This is a concern I have heard echoed a lot. We've heard about potential legal ramifications for doctors, but what have we seen so far in terms of what might be in store for pregnant women?
So one of the sort of central tenets, I would say, of the anti-abortion movement for a very long time has been that you don't punish pregnant women, you don't punish pregnant people, you punish people who are abortion providers. And right now, that's sort of still where we are, right? Most of these laws that are bans or that are restrictions, significant restrictions in some cases, are focused on people who provide abortions. And then, of course, we have a couple of states that are also going after folks who aid and abet in the provision of abortions. My prediction, though, is that because medication abortion is such a huge part of abortion provision in the time that we live in now, and because medication abortion doesn't necessarily require that you actually see a healthcare provider, right? I mean, people can buy pills online and can self-manage abortions at home. I think the future might hold more criminalization of people who actually engage in self-managed abortions, which would mean criminalizing people who are in fact pregnant, which is different than what we've seen typically in the past.
I just want to stay with this for one moment. When you talk about abortion done this way, can you just sort of talk me through what that criminalization might look like? So if a woman takes medication, has an abortion, how then might this impact her legally?
So there are a few different ways that states might try to go after this. So one would be to actually try to target people as they purchase pills. One would be trying to target people who are selling pills, both of which I think will be difficult in the world that we live in now. Another would be if someone shows up at a hospital and there is a suspicion that that person has tried to self-manage an abortion. And we've already seen this happen to women in this country, so it would not be so off the charts to imagine that happening here. And particularly for poor women and women of color, those are the folks who we tend to see having their pregnancies criminalized or behavior during pregnancy criminalized. So those are the things that we could, sort of imagine coming down the pike.
We're going to turn to another question, which is this. What might be the health outcomes if women are not able to get the care they need? That was a question shared by readers like Annie from Salem, Oregon, and Wayne from North Chatham, New York. Laura, is there some estimate about who might be impacted and how?
Annie and Wayne, those are really good questions. I think all of us on the webinar today are thinking the same thing. Really, all women who will be pregnant in their lifetimes will be impacted by the restrictions on abortion because whether we like it or not, being pregnant is risky, even in the best hands with the best care throughout pregnancy and in childbirth, women still die in the best hospitals. And as I think you've already heard today, Black women die at a rate of 3 times white women because of our inequities in healthcare. So without an abortion available for a pregnancy that has gone awry, either because of the maternal health, as David talked about, as a high-risk OB person, medical problems in pregnancy can explode. And if the mom is at risk of dying, then the baby will die too. So we often have tensions between maternal and fetal well-being, and it's complicated and it changes really quickly. And that's why legal and external input only impedes that care. It doesn't make it safer for anyone. It makes it worse for everybody, particularly the pregnant woman, but also the care team around her, the nurses and doctors trying to care for her. So everyone who wants to ever give birth or loves someone who wants to give birth, because the maternal mortality without the availability of abortion will absolutely go up. We've seen it since the beginning of time, and it will continue, that without the ability to evacuate the uterus, pregnancy will be much more dangerous.
Kim, related to that, we heard earlier about laws targeting abortion providers, but could doctors also be at risk and be sued if women die from being denied an abortion that they might need?
Yeah, I mean, I think it's a really difficult position to put a healthcare provider in, because on one hand, right, their obligation is to their patient, and if they're looking at a patient who is either at risk of dying or at risk of some other sort of really significant negative health outcome. Maybe this is a person who, if you don't act now, will never be able to get pregnant again, right? I mean, there are lots of different ways that pregnancy can have a negative impact that aren't necessarily about death. So you have a physician who on one hand is thinking, I need to do what I need to do to protect this patient because that's what good medical care is. And on the other hand, you have them saying, but am I putting myself at risk? Am I putting my hospital at risk? Am I putting my employer at risk by engaging in this behavior? And, you know, those are not that I would want my doctor to have if I'm on the table and bleeding.
Okay, so this then speaks to our next question, which is as follows, and this is for both of you. In states where the only exceptions are for the life of the mother, who or what determines that risk? Readers Marianne from Houston, Helen from New York, Terry from Morristown, New Jersey asked that. Laura and then Kim.
Okay. Also a great question. And it does demonstrate to me that the writers of some of the state bans do not ever work in a labor floor, because hospital care for someone who is sick moves so quickly. And it's never one clinician deciding alone when someone's really sick. The way we take good care of patients, and medicine's gotten better and better, is with really high-functioning teams. And these teams on a Saturday at night at 4 a.m, there is no lawyer on call to say, okay, is this mom sick enough that I can now initiate labor and this pregnancy will be over? The baby will die, but if I wait, I don't know, 2 more hours, 12 more hours, the patient might be in septic shock, and then the mom will die. There's no one to consult. When I've had to do an ethics consult, maybe for end of life, or a patient is making choices that I'm not sure, I don't understand them, and I'm not sure they're in her best interest, and I want other people to help with the sort of the ethics and the legal ramifications of our shared decision making. It takes 2 days. I mean, if it happens on the weekend, those resources don't exist. You don't have the Attorney General or your hospital lawyers on your cell phone. And they can't, each patient's experience is so, her clinical dynamics are so complex that having a moment in time, having someone weigh in and saying, well, you know, she's not quite sick enough, you have to wait a little bit longer for her blood pressure to drop. That's a concrete sign of sepsis. Then you can intervene. You know, those resources don't exist. So it's just impractical to have that, oh, if it threatens her life, you doctors can do what you need to do. That isn't, it's not employable in our day-to-day functioning in a busy labor floor. It doesn't protect women who need that care to save their life.
Kim, what are your thoughts on this question?
Yeah, I mean, I think what I would add to what Laura said, which obviously makes, you know, a huge amount of sense. I mean, she's the person who's in the space who has to engage in this shared decision making. But what I would add to that is, you don't want lawyers making these decisions, right? I mean, I've been a lawyer for a long time. I've been a law professor for a long time. My expertise is not in medicine. And so even if you did have a lawyer who was on call, that is not a person who should be making a clinical decision about this patient at this time and what this person is experiencing. And so, you know, some of those calls will end up being made, you know, it'll be sort of Monday morning quarterbacking. But at the time when you are a healthcare provider who is trying to save your patient's life, the last thing you want is to have to pick up the phone and call somebody like me who's going to say, I don't know, what's the best course of action here, quite frankly.
Kim, I want to stay with you for a moment and just ask you this question. Do we have a sense of how effective these laws are? I mean, the stated goal is, of course, to stop the termination of pregnancies. And for those who are against abortion, they see these as a very important tool to stop what they consider to be something terrible. So how effective are they? Do we know?
So one of the things that we know from other countries is that banning abortion doesn't stop abortion. People will still continue to have abortions, and they'll find various ways in order to do that. What we're going to end up with in the United States is people who, if they have the resources, are going to be able to cross state lines in order to get abortions. And right now we're looking at a patchwork where, the gestational ages for abortions bans are all over the place right now, although some of that might settle down. So you're not going to stop abortion by banning abortion. Women have been terminating pregnancies for a very, very long time. And because the landscape is so different, because medication abortion is available now, it's also simply going to be harder to target people and to figure out how to keep them from accessing the medications that they want or that they need in order to terminate a pregnancy. And that sort of goes back to the question that we were talking about before, which is, do you criminalize providers or do you also expand that criminalization to pregnant people? And I do think we're going to see that kind of expansion because, if you are a person who doesn't want anyone to have an abortion, you want to be able to cast the widest net possible. So I think we're going to see a lot of increased surveillance or attempts to increase surveillance of people, whether it is, all the advice that folks were getting to take period trackers off of their phones. Things that just seem absurd. And yet, if you're going to try to target people in that way, you're going to have to start really piercing a veil of privacy that a lot of us thought was both constitutionally protected and morally protected, but maybe not so much anymore.
We heard a bit from our doctors earlier about the effect these laws could have on medical care outside of abortion itself. I'd like to sort of dig a little bit more into that. Could these laws have an effect on fertilization treatments, for example? That was a question from a reader called Heidi in Harbor Springs. Laura?
Yeah, Heidi, I think all of us are also afraid of that. And the answer is yes, because many of the bans, and state by state, describe pregnancy as a fertilized egg before it has reached the uterus and implanted. Now, as medicine evolved, and particularly infertility treatment and IVF got better and better, all of the medical institutions and governing bodies in the US had to crystal clear create a definition of when pregnancy began. And that begins with implantation. Because if you're undergoing IVF and your embryos successfully are fertilized in the laboratory, perhaps even in another state, I'm in New York, so in New Jersey, I'm not pregnant when they call and say, hey, we've just put the sperm and the egg together. It worked. We are getting cell division. Come on in tomorrow. We're going to put them in your uterus and we're going to hope that they stick and they implant. I can't call my friends and say, I'm pregnant. I can say, I think tomorrow I'm going to hope that things go well. So because of that advancement in infertility treatment and IVF, ACOG, the American College of Obstetricians and Gynecologists, the FDA, and the AMA, and the NIH, so everyone who does research, everyone who does oversight, everyone who does medicine, all of those bodies had to come up with a definition of when pregnancy begins. And that definition is with implantation. So if the bans are interpreted as they're written, that interrupting a pregnancy after fertilization, then the people who are doing all this IVF, if they trip and one of the embryos falls, that's considered murder for that doctor. Or if the patient, sometimes the embryos are frozen for later implantation. You could thaw an embryo and it doesn't thaw properly. It happens a lot. It's just like in nature. Many times that a sperm and egg meet in the fallopian tube and they start to divide and become an embryo, but before implantation, they don't make it. And if I would like the audience to just think for a minute in your head, how often do you think that is. Like, what's that number? How often do a sperm and egg meet in nature, in the general population, and they get to the uterus, but they don't implant. They don't even start. It's more than half. So that's just nature. And so in the infertility laboratories, that happens often too, that we thaw an embryo, but it doesn't keep looking healthy enough to put into the woman's uterus and hope for an implantation and hope for a healthy pregnancy. So the chaos and confusion and fear that couples desperately trying to achieve pregnancy and build their families, that is already under threat. So it's parenting, the as Lulu, you keep talking about, like, where are the tentacles of these bans? And just building healthy families are going to be challenged because of our treatment of infertility, treatment of miscarriage, treatment of ectopics, treatment of high-risk pregnancies. It's everything we do in OBGYN is affected.
I mean, Kim, speaking of the tentacles that Laura is discussing there, I have a question from readers Cynthia in Italy and Pamela from the Bronx, which is this: do the existing bans or proposed legislation in some states affect the availability of contraception, of contraceptives, or sex education?
So the contraception question is one that we should all be deeply concerned about. So what we've already seen in previous cases, in particular the Affordable Care Act case that involved Hobby Lobby and coverage of contraception, and one of the claims that was made by Hobby Lobby was that they didn't want to cover certain types of contraception because, as far as they were concerned, they were basically, they had the possibility of creating an abortion, and they were defining an abortion as anything that kept a fertilized egg or had the risk of keeping a fertilized egg from implanting in a uterus. So that is a very broad definition of abortion that is wide enough to capture various types of contraception. So we should absolutely be concerned about what's on the table when it comes to contraception. And the other thing that I want to just sort of add to the answer that Laura was giving was that, you know, as the Supreme Court talks about the state's interest here, the state interest isn't necessarily in fetal life, it's in potential life. And once you say potential life instead of fetal life, then you definitely start to expand into embryos, you start to expand into contraception in ways that that I think a lot of folks weren't really anticipating when they thought about what an abortion ban would look like.
Earlier in July, the health... Yeah, please jump in, of course.
Well, Kim, I'm curious what your thought about this is, but when I think about potential life, if we really think about that, why isn't every ovulatory cycle or every ejaculation potential life?
And there are absolutely people who think that is true, right? And the question is, how would you operationalize that in law, which would be very difficult to do. And so there are spaces where it becomes much easier, including when you have an embryo. So just to give another example, Arizona passed a law not so long ago to deal with the question of embryo disputes. So when you have two people and they, use their own gametes, their own egg, their own sperm, or even buy them and create embryos, and then they end up getting divorced or they separate and they know one person doesn't want to use the embryos anymore and the other person does want to use them. Typically, what courts have said in those cases is that the person who doesn't want to reproduce is the person who should win, right? Nobody should be forced into pregnancy in that set of circumstances. But what Arizona did not so long ago is they passed a law that said if there's an embryo dispute, that the embryo should go to the person who is most likely, right, who has the greatest chance, I should say, of bringing those embryos to fruition. And so there's this sort of underlying element of what's going on here, which is about expanding what it means for us, one, to think about potential life, but also what it means for us to think about how we protect persons and who we define as a person. And as we widen that lens, that also has significant impacts, not just on contraception, not just on abortion, but on fertility treatment, on adoption, on all sorts of different things.
That's fascinating. That really is fascinating. I have finally this question from a reader, Jared from Hamden, Connecticut. What is the role for resistance by the medical profession, if indeed they wanted to resist, in the face of what they may deem to be unjust laws, where the demands of the law come into conflict with the ethical requirements of the profession? That is the question.
Kim, you want to go first, or you want me to go?
It's a tough one.
Yeah, you can talk about it from the physician's side, and I'll talk about it from the lawyer side.
Okay. Jared, that is probably the most exciting and terrifying thought, because I think depending on how I get up in the morning, I want to try to start a revolution for all the physicians and nurses and midwives. And, we do good medicine with really filled out teams, that all of us should protest and just not go to work until this conflict of our Hippocratic oath and using science and good medicine that's very clear. There's no gray zone in the safety need for abortion, for safe pregnancy and healthy society. It's the data is robust. So to not use science and then not fulfill our ethical duty, it's unheard of, and it's so jarring is the best word, that I feel like we have to do something really radical. And yet it's so different by state. I'm in New York, and I've had just an outpouring of support from our hospital leadership, our department leadership, our legal leadership, New York State, the governor, pro bono lawyers. It's sort of like, we will take care of women from less fortunate environments. But and yet we still feel like we want to work within the systems that we've believed in our whole lives. So I think that depends on the day whether I want to try to, start trying to get physicians to feel, and not just, more in America today, more doctors are employed in hospital or health systems than in private practice. That's an evolution in my lifetime, that it's not really a cottage industry of small businesses, but really we're employed. So there's we need the whole medical forces and power structure to be loud and demanding that we can't have our hands tied like this, because we can't function in a space where we are at conflict with science and with our moral compass. We just can't. So protesting, going to work, I don't know.
Well, Kim, hearing what Laura said there, I imagine there's some legal ramifications to doctors who would feel that way and would want to act on it.
Yeah, absolutely. So on one hand, there are undoubtedly abortion providers who are going to both go up to the line and over the line in terms of, laws that are vague. And so they will continue to provide the care that their patients need. We've also had some progressive prosecutors who've come out and said, we will not be prosecuting people under these bans. And that's a really powerful position for prosecutors to take, certainly. There are other people in the healthcare field who potentially have opportunities here to, again, stand in solidarity with their patients and with other healthcare providers and say, we're going to provide the care that we need to provide for these patients. And part of what's difficult here is that for some of these statutes, it's possible that a court is not going to allow a challenge to them unless it is a challenge based on an actual person in a set of circumstances where something potentially negative has happened or is at risk of happening. And what I'm describing is the difference between what we would call a challenge to a statute on its face. So before it even goes into effect, we say this is going to have a really bad outcome and we've got to stop it from going into effect, versus a challenge as applied. So we have to actually wait until somebody is at risk, and that person becomes your plaintiff. So, there are always these places, I think, where people who have been providing abortion care in this country, whether it was risks that come from protesters, whether it was risks that come from violence against abortion providers, and we have seen significant violence against abortion providers in this country, where folks have to make some really tough decisions that they shouldn't have to make because they're just trying to provide medical care.
I really want to thank you so much for this illuminating conversation, Dr. Laura McIsaac with Mount Sinai Health System and Professor Kim Mutcherson of Rutgers Law School. We appreciate your time and your insights. Thank you both so very much.
Thanks for having us.
That's our program for this afternoon. So much of what we learned came through stories, and that is the premise of our podcast, First Person, which illuminates big ideas that shape our world through personal conversations. You can catch it wherever you get your audio content. And a big thank you to the subscribers of the New York Times. You make all of this work possible. So thank you for supporting the excellent journalism that you see here today. And if you missed any part of this event, a recording will be on the page shortly. Thank you and have a great rest of your day.